We've got a presentation here on BUMED Instruction 6300.19, Primary Care Services in Navy Medicine. All right, so first we got to talk about what primary care is. Primary care is the integrated, comprehensive, and continuous way of meeting the healthcare needs of our patients by the Navy medicine team. So what that means is this is usually where our patients interact with medicine, right? This is their introduction to Navy medicine. Most of the time, unless it's an emergency and they go straight to the ER, their first interaction will be with their primary care provider. They're going to go either to one of the clinics, or if they're operational, they're going to go to the battalion aid station, and they're going to be seen in that setting. Primary care is going to include things like readiness, especially for our active duty, making sure you're ready to go, that you're fully medically ready to deploy. It's going to deal with prevention wellness, having you come in for periodic screenings. Your periodic health assessment is trying to identify diseases early on or before they start. A well woman exam, screening for cervical cancer, screening for colorectal cancer, screening for breast cancer. All that kind of stuff falls under the realm of primary care, or gets initiated at least by primary care. And also behavioral health, your mental well-being, your mental health, that all falls under primary care. And then of course disease management. When you do have an illness, it's up to your primary care to either handle it on that level if that's appropriate, or to put you on to a specialist, like if you need to see a neurologist because your migraines are getting out of control, or if you need to go see an endocrinologist because your diabetes is getting under control, or if your blood pressure is getting under control, they send you to internal medicine. But that's all done through your primary care. That's the initiation of it anyway, usually through a consult or something like that. The hallmarks of primary care are going to include quality, safety, and readiness. Those are the hallmarks of primary care, at least in Navy medicine. And our measures of success, whether or not we are providing primary care in a successful manner, it's going to be measured in our quality of care, our continuity, meaning that when you come in, you see the same people. Like if as much as feasible, you follow up with that same provider, and you follow up at an appropriate interval. And enhanced access, you're able to get the appointments you need, you're able to get the medication refills you need, and also patient and staff satisfaction. All right, so the patients are happy with their care, they feel like they're receiving quality care, and your staff are happy with the way the clinic runs and how their careers are progressing. The way we're going to deliver primary care in the Navy is going to be what we call medical home port. Medical home port is based off and aligns with the civilian model of primary care that is known as patient-centered medical home, PCMH. Patient-centered medical home enhances access, care quality, outcomes, and overall patient satisfaction. All right, so patient-centered medical home, and what we model medical home port off of, access and quality of care are huge with this. Okay, we don't want patients waiting for a long time, and we'll get into the intervals for specific appointments, but we want to make sure patients can get in to see the providers. That's what it's all about. That's how we measure whether or not we are running, and qualified in medical home port. All right, it also is going to enable better resource requirement projection and planning for the future, based off of how the facility is supposed to be set up, based off the staffing levels, based off the patient empanelment. It's supposed to give us a better idea of what the patient flow will be like, so we can appropriately plan, our schedules, and we can appropriately plan what things will look like in the future for that clinic. So when we have a primary care clinic that needs to become a medical home port clinic, they need to follow that model. A couple things need to happen, and we need to discuss a couple organizations. The first organization we're going to talk about is the National Committee for Quality Assurance. The National Committee for Quality Assurance, these guys are the ones that set the standards for the civilian model of what we're trying to achieve for the patient-centered medical home. Okay, they're the ones that qualify these as patient-centered medical home clinics. All right, this is the model we've adopted. Navy Medicine is adopting those standards. We're going to follow these same standards. The National Committee for Quality Assurance is established for civilian patient-centered medical home. Those are going to be the same standards we set up for medical home port clinic. All right, so in order to become a medical home port clinic, it's going to happen in two tiers, or two levels. Okay, first we'll talk about level one. So National Committee for Quality Assurance. Level 1, right, that needs to happen within 4 months. Not only that, it'll be self-assessed. So when the clinic gets tasked with becoming a medical home port clinic, they'll have 4 months to get to level 1, but they'll make that determination. They will look at the standards put up by the NCQA, and they'll see whether or not they meet those standards. And once they do, they can go ahead and call themselves NCQA level 1. All right, after that, they're going to move on to level 2. So NCQA level 2, right? That needs to be done within 6 months after level 1. So meaning after they first get tasked with becoming a medical home port clinic, they have 10 months total, 4 months for level 1 and then 6 months for level 2 for NCQA. All right, so when they feel that they're ready for NCQA, they actually need to send a message to Navy Medicine Region Commander. For instance, if this were a clinic on Camp Pendleton, right? This is a Naval Hospital Camp Pendleton clinic. When they were ready to be NCQA level 2, they need to send a message to Navy Medicine West. Navy Medicine West will then send a message to the Bureau of Medicine and Surgery, or BUMED. Okay, BUMED is going to go ahead and let the NCQA know, the National Committee for Quality Assurance know, like, hey, we've got a clinic that's ready for NCQA level 2. And what will happen is a representative both from BUMED and the NCQA will go evaluate that clinic and see whether or not they are qualified for level 2. And then that will be a medical home port clinic. So one of the key emphases on medical home port is access to care. All right, in order for patients to get access to care, their clinicians need to be available. So next we're going to talk about clinical provider availability. All right, a clinician who is available for 36 bookable hours each week will be defined as a full-time equivalent of 1.0, or an FTE of 1.0. So this means if at 36 hours a week, this provider, right, whether it be a physician, a PA, a nurse practitioner, an IDC, if they have 36 hours in which they are available to see patients, they are an FTE of 1.0. All right, and the way these work is that everything from there on will be based off these hours. So say we had a clinician who is only available for 18 bookable hours. Well, 18 is half of 36, right? A full-time is 36. So that FTE, that full-time equivalent, would be 0.5. It'd be half of this 1. All right, so that's what it means by these full-time equivalents. Somebody who's 36 is 1.0. Everything is based off of that. So if like this person was available for some reason for more than 36 bookable hours each week, it would be a number larger than 1.0. It'd be a percentage of 1.0. All right. Providers should be in the clinic to the maximum extent possible. This is stressed so much throughout this instruction. They want providers seeing patients. That's what this is all about in order to increase access to care. Right? There are administrative discounts for collateral duties, but they have to be approved by BUMED. Right? So a provider who doesn't have a big collateral duty, they need to be available for these 36 hours. In order to get discounted some of this time, it's got to be approved by BUMED. It's got to be a collateral duty approved by BUMED. Physicians who are faculty members for family medicine training programs are authorized absence from clinical care responsibilities. All right, so if this is a training clinic, right, where residents are there to be trained, well, if you're a faculty member responsible for that training, you're going to be authorized not, time away from clinical responsibilities because you're going to have to train residents. You got to train doctors, right? So the American Council for Graduate Medical Education, the Residency Review Committee mandates that 1,400 hours per faculty full-time equivalent per year be spent in resident teaching, oversight, or other faculty-related activities. So what's that saying is for every full-time employee you have dedicated to residency training, they've got to spend 1,400 hours a year doing residency training. So next we're going to discuss patient empanelment. Another big thing with medical home port is continuity of care. So patients will be assigned a provider, right? They're going to get what's called their primary care manager, the person that they're supposed to see when they have an appointment for the sake of continuity, for the sake of, your provider actually getting to know who you are and know what's going on with your health. They'll belong to a team, but they'll also have the primary care manager who they'll see unless for some reason they're unavailable. They'll see somebody else on that team, right? And we'll get into that in just a little bit. So each provider on the team should have at a minimum 1,100 patients empaneled to them, meaning that those 1,100 patients, right, when they come in to get seen, they should see that provider. He's responsible for 1,100. He or she is responsible for that 1,100 patients, but no more than 1,300. Minimum of 1,100, a maximum of 1,300. Those belong to that provider. He's responsible for their overall health and well-being. So when they come in to get seen when they're sick, when they come in to get seen for periodic assessments and things like that, they should see that provider. They're empaneled to him. All right, medical home port clinics are reward based on a per enrollment patient formula that assesses outcome, access, satisfaction, and other measures. Okay, so it does no good for a clinic to just try to see as many patients as they can, to panel as many patients as they can, because that's not how they're going to be rewarded. That's not how that clinic's going to get extra money. The way they're going to be evaluated whether or not they're doing a good job is per enrollment patient formula, right? That's going to say, hey, what was the access to care like? Can you get in, and see your provider within 24 hours or 1 week, depending on type of appointment? Right? Are you satisfied with your care and some other things? So it does no good to go beyond the 1,300 empanelment. Okay? Panel size in excess of the ceiling are not authorized unless approved by the Navy Medicine Regional Command. All right. And then home port clinics are only responsible for patients enrolled in their clinic. So that means if somebody is enrolled to another medical home port team, they should not go to your clinic. They shouldn't be seen. We've only got a couple exceptions. Okay. So our exceptions are going to be newborns of enrolled patients who are less than 60 days old and awaiting TRICARE enrollment. Well, we're going to go ahead and see those newborns. Okay. And then in some instances, we might be called upon to see foreign nationals or dignitaries. All right, but MTFs, they should not enroll students who are assigned to the command for less than 179 days. And typically there shouldn't be, right? Anybody who's transient, only anybody there that just for training, they're not going to get seen by the home port clinic. A lot of times what will happen is there'll be a clinic set aside specifically for them. And like I said, you're not there for a very long time. So you shouldn't be there to, get referrals to specialists and have a lot of things going on. Otherwise, you probably shouldn't be in training. Moving on to provider team staffing. So each medical home port team will have at least a 3 to 5 provider team, right? Privileged provider, somebody who can prescribe meds, order consults, order studies like CT scan, X-ray, MRI, things like that. Okay. And then we got to talk about the specifics that go in to each type of provider team. So if you've got 3 providers on a team, 4 providers on a team, and 5 providers on a team, we got to know about the number of physicians and the administrative discounts they're allotted. Okay, the administrative discounts being time away from seeing patients, time away from clinical duty. Okay, so 3 provider teams, they've got to have at least 1 physician on the team, and they get 0.75 full-time equivalent administrative discount. So remember that a 1.0 full-time equivalent was 36 hours. So 0.75, that would be 75% of 36 hours would be 27 hours. So the 3 provider team gets a 27-hour administrative discount per week. Okay, a 4 provider team, right, they have at least 2 physicians on a 4 provider team, and they get a 1.0 full-time equivalent. Remember, a full-time equivalent employee was 36 bookable hours. So they get, between the 4 providers, they've got 36 hours that they can spend on an administrative task between the 4 of them. Okay, then your 5 provider team, there's still, again, at least 2 physicians on that team, and they get 1.25 full-time equivalents of administrative discounts. So that would be 45 hours a week between the 5 providers that they can spend on administrative duty and away from clinical duty. Okay, and then command should strive to ensure that at least 50% of each provider team is civilians, and that's to accommodate things like going on training exercises or getting deployed and all the things that happen to military medicine, military providers. So we want at least 50% of them to be civilian, so we can maintain that continuity of care, that there's somebody on the team that is still there when when somebody gets mobilized. All right, so supporting staff. All right, so we're going to talk about the team clinic nurse. All right, usually this is a RN. We're going to talk about ancillary nursing personnel. This is like a licensed vocational nurse, your basic hospital corpsman, your certified nursing assistant, your CNA, and your medical assistant, your ancillary nursing service. And we're going to talk about clerical staff. All right. And the way we're going to staff them, the way we're going to number them is per full-time equivalent physician, okay? Our provider, that is, okay? So for every full-time equivalent, for every provider that we have working 36 bookable hours, we need 0.5 team clinic nurses. So that would mean to get a team clinic nurse, you need 2 providers that are working full time, that are working 36 bookable hours. All right. For ancillary nursing personnel, you get 2.5. Okay, so if you have 2 physicians, that would be 3 corpsmen, or 3 licensed vocational nurses, or 3 CNAs, or 3 medical assistants. And then your clerical staff, you get 0.75 per full-time equivalent provider. All right. Behavioral health providers, well, we get 1 of those per 7,500 enrollees. So if the clinic overall has 7,500 people it's responsible for, they rate a behavioral health provider. They should also get a nurse or health educator, 1 per 7,500 enrollees, and they should also get a case manager for every 7,200 enrollees. Case manager would be somebody that helps somebody that has like a complex case going on, that needs to coordinate with all sorts of different specialties. You know, they're not only are they seeing their primary care, but they're seeing neurology, and they're seeing physical therapy, and they're seeing orthopedics, and oh, by the way, they've got like occupational health. You know, they've got things going on with medical devices, stuff being delivered from home, dealing with TRICARE. That needs a case manager to assist that patient, make sure they're getting all the appropriate care, and, you know, give them a little bit more attention than most other patients would otherwise need. All right, next we got to talk about our appointment types. So we've got 4 appointment types, but it's actually more about 4 groupings of appointment types. Okay, so our 4 groupings of appointment types, we do acute appointment types and open access appointment types. We're going to do established appointment types, wellness appointment types, and then procedure appointment types / specialty specialty appointment types. Excuse me. All right, so acute appointment types. Right, these patients need to be seen within 24 hours. If we put them in Alta CHCS as acute, they're supposed to be seen within 24 hours. Open access appointment types are similar, but these guys are seen on the same calendar day. Okay, so if you come in the morning or you come in the afternoon, you know, if it's less than 24 hours, technically you can get the acute appointment the next morning, the next day. Whereas an open access appointment type, that's supposed to be on the same calendar day. Established appointment types, this kind of patient is seen within a week. So this is when somebody comes in for something, you know, that's not urgent, that's not acute, that's chronic. We want to try to see these patients in a week. When somebody tries to establish a wellness appointment, we need to see this patient within a week as well. Okay, a wellness appointment would be something like coming in for a well woman exam, coming in for your PHA, or some sort of physical or screening or anything like that. We want to try to see these patients within a week. And then when it comes to procedures and specialty type appointments, usually we just have a day for this. Like I think it gives an example of when we're going to do our stress testing, or we're going to do like our coloscopies, or any kind of special test. Like a lot of times if you work in a BAS, you have wart day, right? You just have a day when anybody needs their warts frozen off. They come in, I don't know, like on Tuesday morning, right? And it just kind of streamlines things to do it that way. So procedure type appointment and specialty type appointment, they're usually grouped on the same day for the sake of efficiency, all right? Acute appointment within 24 hours, open access appointment, same calendar day, established and wellness appointments within a week, and then our procedure and specialty seen on the grouped on the same day. We have a special day for that appointment. All right, and no other appointment types are authorized. Under medical home port, this is the only way we can put an appointment in. All right, facility standards. All right, so the clinics that we are providing this medical home port care in, right? Key members of the primary care team should be located in the same space. Each medical home port clinic shall have 2 exam rooms per provider, all right? So we can move patients along, so we can get in there and see them. We should have 2 rooms per provider, all right? We also need a room that is designated for procedures or prolonged acute patients for care and monitoring, okay? So when you're taking out that ingrown toenail in the clinic, right? When you're doing that incision and drainage of an abscess, you should have a special room for that. Or when you need to give IV fluids and your patient's going to be in there for a minute, you should have a special room just for that, so it's not taking up your 2 rooms, so you can continue to see your other patients. And there should be one private multi-purpose office that's shared by all the team members as well. All right, let's review what we've gone over. All right, what organization has established the nationally recognized standards for patient-centered medical home, the civilian model of what we're trying to do with medical home port, right? Who sets the nationally recognized standards? All right, that is the National Committee for Quality Assurance, the NCQA. Within how many months will a new medical home port clinic attain a level 1 NCQA recognition? All right, within how many months should a medical home port get level 1 NCQA recognition? They got to get that done within 4 months. 4 months to get that NCQA level 1 recognition. After obtaining level 1 NCQA recognition, how many months does a medical home port clinic have to achieve level 2 recognition? After level 1, how many months do they have to get level 2? 6 months, okay? So that means 10 months total to get to level 2. What does the commanding officer, the CO, or the OIC of an MTF, does the commanding officer, CO, or OIC of an MTF notify when their clinic is ready for NCQA level 2 recognition? Right? Who are they going to let know? They're going to let their Navy Medicine Region Commander know. All right, who does the Navy Medicine Region Commander forward the level 2 recognition request to? Who are they going to forward it to? They're going to forward it to the Bureau of Medicine and Surgery, who will then go ahead and forward it to the National Committee for Quality Assurance, and then a representative from BUMED and from the NCQA will go evaluate that clinic. How many bookable hours does a clinician require to be considered a 1.0 FTE, a 1.0 full-time equivalent? All right, that physician needs to be, our clinician needs to be bookable for 36 hours, right? 36 bookable hours. What is the recommended empanelment range for a provider? What is the recommended empanelment range for a provider? Provider should see a minimum of 1,100 and a maximum of 1,300 patients empaneled to him, patients that belong to him. Right? What are the exceptions a home port clinic can make when providing the care to a patient who is not enrolled in their home port team? What are the exceptions a home port clinic can make when it comes to providing care to somebody who's not enrolled to them? All right, the exceptions are newborns of patients less than 60 days old, and they can also make exceptions for foreign nationals and dignitaries. All right, students cannot be enrolled in home port if they are on station less than how many days? Students cannot be enrolled in a home port if they are on station less than how many days? Less than 179 days, you're not getting enrolled in medical home port. What percentage of a provider team should be made up of civilians? What percentage of a provider team should be made up of civilians? All right, 50% of your team should be civilians, okay? So we can keep that continuity of care. If something happens with your military providers, if they get deployed or if they go on a training exercise, you still have providers from the team there maintaining that continuity of care until we can get more providers on board. All right, in a 3-provider team, how many of the providers have to be a physician, and what is the maximum administrative discount for the team? In a 3-provider team, how many have to be physicians, and what is the maximum administrative discount for the team? Well, they've got to have 1 physician, and they get 0.75 full-time equivalent administrative discount. In a 4-provider team, how many of the providers have to be physicians, right? And what is the maximum administrative discount for that team? Right, 14 provider team, right? They've got to have 2 physicians and they get 1.0 full-time equivalent administrative discount. And a 5-provider team, how many of the providers have to be a physician and what is the maximum administrative discount for that team? All right, for a 5-provider team, it's still 2 physicians and they get 1.25 full-time equivalent administrative discount. Right, how many exam rooms are required per provider? How many exam rooms per provider? Well, you get 2 exam rooms per provider. Remember, you get the other procedure room as well, right, in the facility. Within what time frame must a patient be seen when they have an acute type appointment? Within what time frame must a patient be seen when they have an acute type appointment? Acute type appointments we want to see within 24 hours. Within what time frame must a patient be seen when they have a well type appointment? All right, when they have a wellness type appointment, we're going to see that patient within a week. Within what time frame must a patient be seen when they have an open access type appointment? Open access type appointment, we're going to see these patients on the same calendar day. Within what time frame must a patient be seen when they have an established type appointment? When they have an established type appointment, we are going to see them within a week. All right, this concludes this presentation. Your resources on this one are your BUMED Instruction 6319, your primary care for Navy medicine, also your National Committee for Quality Assurance, and then also the Accreditation Council for Graduate Medical Education. Like always, I hope these help, and keep studying.